there are a number of considerations when we try to choose the optimal treatment for our patients in the second-line setting. First of all, we need to take into account the timing of progression, so whether this is primary or innate resistance to immunotherapy, or whether this is delayed or secondary resistance to immunotherapy, and the biology of those tumors are completely different. Second, we have this challenge of the lack of a homogeneous definition in what we call immunotherapy resistance, ranging from 3 up to 9 months according to the clinical trial. And this poses additional challenges. We also need to take into account patient-related characteristics such as the burden of the disease, the presence of symptoms, the preference of the disease that we should always discuss with the patient and his or her family, the pattern of disease progression, so whether this is an oligo progression or a systemic progression, these two can be managed in totally different ways. And finally, we need to also take into account the imperative importance of availability of next generation sequencing. So we should always try to have NGS data available for our patients. Even if they didn't have NGS testing in the first line, we should try to perform NGS in the second line setting. But even if they already had NGS in the first line setting, we should try to rebiopsy them in the second line setting to identify potential mechanisms of resistance to immunotherapy and potential new therapeutic targets.